Assalamu alaikum wa rahmatullah. My name is Nizar Bahabri. I am an internist and an infectious disease consultant. And I'm going to speak today about one of the most common diseases that we see in Saudi Arabia. As you all know, diabetes is the most prevalent chronic disease in Saudi. It accounts of around 25% of the population. If you added the pre-diabetic, then the statistics jump to around 36% of the population. That means that we are going to deal with diabetics as internists in a daily basis. And we are going to deal with the complication of diabetes nearly in a daily basis also. And our mission is not to treat complication. Our mission in reality is to understand complication and prevent them by screening and to try our best with our patient to control their blood sugar. But for the purpose of our lecture, I'm going to speak today about one of the most common complications of diabetes. And we are going to go through all of them, including their management, their risk factors, and the way that we should deal with it in the form of screening to take the best care of our patients. So let's go ahead and start. In the end of this lecture, we will be talking about the pathogenesis and important complication of diabetes type 2, to screen the patient for such complication, and to provide preventative measures and to treat such complication. And how should we deal with our patient and their families to prevent those kind of complications? So the chronic complication of diabetes are a lot, but we are going to concentrate on the following. First, we are going to discuss in a very simple manner what is the mechanism of diabetes complication. Then it will be followed by the eye complication in diabetes, followed by the renal complication, and then the nervous system complication will be followed by cardiovascular complication and diabetic foot, which we see a lot in our country, and then many other diabetic complications. So please tune with me and let's start. We'll start with the pathogenesis. Four main mechanisms of pathogenesis that all of those diabetes complication will happen from. Number one is the increased polyol pathway flux. And the second one is the increase in the intracellular advance of glycation and produce of the AGE formation. And the third pathway is the activation of protein kinase C, which will increase inflammation in the cellular level and increase in the hemocyanin pathway flux. Just to summarize, all of those kind of pathways will deal into the cellular level mainly to increase inflammation. And inflammation will lead to destruction, leak of proteins, and then followed by fibrosis. And this will lead to a lot of those complications that is related to diabetes. And therefore, controlling the blood sugar will be repeated again and again. It's the mainstay of prevention of all the complication. This is what we try to do day and night. If you want to decrease all of those pathways and to decrease all of the complication, you need to decrease the inflammation by controlling blood sugar. I hope this will be so clear to move on to the next first complication. In all the complication of diabetes, there was a phenomenal description in the literature speaking about the relationship between genetics and those complication prevalence. So it had been shown into a lot of the cluster families that have diabetic type 1, that if a cluster family have, let's say, a retinopathy, then they have a high tendency, their brothers and sisters, up to 70 and 80%, that they will develop retinopathy also, compared to 17 to 18% where the families are not related genetically to have diabetes complication. And therefore, just to summarize this slide, we want to make sure that you all understand that if you see any of your family, any of your patient's family that have a son or a brother who have diabetes with complication, you have to be worried about the other siblings because they will have higher tendency of getting the same complication like the first one. One of the most common diabetic complication is the eye complication of diabetes. And as you can see, there are mainly three. First is diabetic retinopathy, cataract, and glaucoma. The first one in the eye complication is diabetic retinopathy. Diabetic retinopathy, it is mainly two stages, the non-proliferative and the proliferative diabetic retinopathy. The non-proliferative is usually comes early, and usually in some studies it will be preceded by, before the diagnosis of diabetes, by mainly around 5 years. The non-proliferative diabetic complication and diabetic retinopathy, it's mainly in the earliest stage of retinal involvement. It will be a change in the microorganism with some dot hemorrhage and exudate and retinal edema. This retinal capillaries leak of lipids and red cells will cause some retinal ischemia and deposit. This can lead to the macular, clinically significant macular edema, which is most commonly presented to the patient as decreased visual, or they will see some haziness in their vision, and it might lead to visual impairment in diabetic type 2. On the other hand, proliferative retinopathy is growth of the new capillaries with fibrosis of the tissue and the retina into the vitreous chamber, and this will be more common in diabetic type 1 and prior to proliferation of new capillaries and pre-proliferative phase that will lead to ischemia and the cotton wall spots. You remember, this is part that will be repeated in a lot of your exams, that you will see cotton wall spots, which is mainly infarcted small areas in the retina. And this will come a lot in your exams, and this is mainly related to the proliferative type of retinopathy. I just put some examples of pictures. As you see, this is non-proliferative diabetic retinopathy. We said there is some hemorrhage, some aneurysm in the vessels, and there will be some hard exudate. And this is another true picture of the fundus. And you can see, as you said, some exudate, some hemorrhage, and some proliferation of the vessels. On the other hand, the proliferative one, as you can see, there is a lot of abnormal small vessels that will develop in the retina. And this will lead to fibrosis, and sometimes, as we said, it will lead to ischemia, the cotton wall picture. As I said before, there is a lot of studies which will show that the prevalence of retinopathy, sometimes it can precede the diagnosis of diabetes by sometimes up to 5 years. And this is proven by a well-done studies that was published in Diabetic Care in 1992 by Hertz, that shows in people that in Wisconsin in blue line and the people in Australia in the red line, it showed that retinopathy have been there in the eyes of 10 to 20% of the diabetic patient, and some of them it will be there around 5 years before the diagnosis of diabetes. The incidence of diabetic retinopathy over time also will increase. So it's one of the most common complications to develop with time. And one of the late complications that will appear, but unfortunately, when it happens, is most of the time it's non-preventable and difficult to be treated, and it will lead to a very difficult complication on the patient life, which is blindness. We are going to speak about this study again and again in most of our complication. A study was published by Al-Wakil in the Annals of Saudi Medicine in 2008 that shows that background retinopathy will appear in around 11% of the population, and it will take around 14 years in mean between the time of diagnosis and the complication of your patient. Therefore, this is something to keep in mind whenever you are seeing a patient and he is diagnosed since more than 10 years. This is more to emphasize that he has to check his eye, because this is the time that you can prevent further damage and retinopathy of your patient. And in another study also have been shown that diabetic retinopathy published in Saudi, it will occur in most of the patients between 10 to 15 years of the diagnosis of diabetes. Treatment of diabetic retinopathy, it's mainly the photocoagulation, especially for the severe non-proliferative retinopathy. And vitrectomy for severe proliferative diabetic retinopathy with a vitreous hemorrhage and traction of the involvement macula is the treatment for the proliferative part. So remember, the photocoagulation is mainly for non-proliferative, and the vitrectomy with vitreous for the vitreous hemorrhage is your way to treat proliferative diabetic retinopathy. There is no contraindication, and this is, I want to emphasize again and again, there is no contraindication of using aspirin in patients with proliferative retinopathy. Keep this in mind. Yes, there might be hemorrhage, but there is a misconception, misbehavior of not using aspirin in patients who have proliferative retinopathy. And this is to confirm, yes, you can use aspirin in proliferative retinopathy. Okay, so if we want to say few important lines about prevention of diabetic retinopathy, it's mainly going to happen, and we are going to say it again in every diabetic complication. It's mainly the good glycemic control, good blood pressure control, and smoking cessation. And there are many studies which will confirm if you have a diabetic control of a hemoglobin A1C of 7, you have much better decline in development of diabetic retinopathy. And as you can see in the graph, this is very clear. It's the relationship between the percentage of diabetic retinopathy that will occur compared to the hemoglobin A1C. As you can see, the percentage will be increased significantly as much as you move to hemoglobin A1C of 9 and 10. This will be significantly related to further damage and further diabetic retinopathy. Diabetes and cataract. There are mainly two types of diabetic cataract. One is the subcapsular cataract, which occur predominantly in type 1 and may come on fairly rapidly with a significant correlation with hyperglycemia and uncontrolled diabetes. And it have one of the significant pictures and phrases that can be describing this phenomena is the snow wolf appearance. And this is mainly, if you see this is in a question, this is mainly related to subcapsular cataract, and it's mainly related to diabetic retinopathy, and mainly related to diabetic type 1. So if you see in any question, you see that this is diabetic type 1 who is having some kind of eye complaint, and they tell you that it shows snow of appearance. This is most likely a subcapsular cataract that you have to take care of. The second one is senile cataract, which is the presence of sclerosis changes in the lens nucleus, and it's the most common type of cataract found either in diabetic or non-diabetic adults, and tend to occur in younger diabetic patients, and particularly with poor glycemic control. The pathogenesis of it's mainly glycosylation of the lens and the sorbitol accumulation. The sorbitol accumulation in an insulin-dependent lens will lead to osmotic changes, and ultimately it will lead to fibrosis and cataract formation. So let's say again, the main mechanism of pathogenesis of cataract is mainly sorbitol accumulation, which will lead to osmotic changes and fibrosis. Then it will lead to cataract formation. Glaucoma, it occurs around 6% of the diabetic patient, and this generally represents a usual therapy of open-angle disease. Close-angle glaucoma can result from neovascularization of the iris in diabetic persons, but relatively is uncommon, except after cataract extraction, which can accelerate new vessel growth, and then it can lead to a closed-angle glaucoma. So remember, glaucoma, it's mainly open-angle glaucoma, which is common to happen in diabetics, and it can be treated with a regular follow-up by the ophthalmologist. So ophthalmic examination, and this is what should be the schedule. In diabetic type 1, it's within 5 years after diagnosis, and then it should be done in a yearly basis. In diabetic type 2, the time of the diagnosis, and then in a yearly basis. In pregnancy, in pre-exciting diabetes, prior to conception, and during the first trimester, on the risk of development of progression of neuropathy. And you will follow up this diabetic gestational diabetes. You will have a close follow-up throughout pregnancy and 1 year postpartum. So the follow-up of diabetic retinopathy will stop after gestational diabetes 1 year after delivery. Now we will move on to the renal complication of diabetes. It is mainly that we all see on a daily basis is mainly the diabetic nephropathy. It's mainly what we see on a daily basis is the diabetic nephropathy. Then it can have also infection is part of the complication. Diabetic patients will have more tendency to have pyelonephritis and cystitis. And also we cannot forget the renal tubular necrosis, which is usually follows a urethral or a contrast-induced nephropathy. So diabetic nephropathy. In an early stages, it will be accompanied by hyperfiltration. But mainly this will happen in diabetic type 1. And then moderately increase in the albuminuria, formerly called microalbuminuria, which is defined by urinary albumin extraction between 30 to 300 microgram per day, or between 30 to 300 microgram per gram of creatinine in a random urine sample. And this is usually, it's part of your workup in a diabetic patient to follow closely the complication of diabetic nephropathy. And we usually do this test so we can interfere early and prevent the progression of diabetic nephropathy. So In a severely increased albuminuria, it's formally called macroalbuminuria, which is defined by more than 300 milligram per day. In the absence of effective therapy, followed by slowly progression decline in the glomerular filtration rate, this will lead to end-stage renal disease if you do not interfere and start the patient on treatment. That will decrease this macroalbuminuria. The prevalence of diabetic nephropathy, it's really very prevalent in diabetic type 1. It's around 20 to 30% within 15 years. It will reach up to 40% within 20 years of diagnosis of diabetic type 1. And end-stage renal disease in diabetic type 1, it usually can occur up to 17% within 20 years of diagnosis. In diabetic type 2, nevertheless, there is a chance of 15 to 30% that they will develop some kind of renal disease within 10 years of diagnosis. This has been proven in UK PDS. This was proven in UK PDS study that at 10 years following the diagnosis, the prevalence of moderately increased albuminuria can reach up to 25% of the population. Over 40% of the new cases of end-stage renal disease around the world will be related to diabetes. Diabetic nephropathy is the second most common chronic diabetic complication that occur in Saudi population. It can occur up to 32% of the diabetic patient. They will have some kind of diabetic nephropathy. And usually it will occur within the mean of around 12 years. And this has been shown in 2 studies that it will occur between 10 to 12 years since the day of diagnosis with diabetes. And therefore, we need to protect our patients. Clues to suggest that what happens, there are always, you will find a case that you will face and you will ask, is this renal failure secondary to diabetes complication? Is it a nephropathy? Or is it an acute non-diabetic related complication? Now we will describe some of the clues that will differentiate between a diabetic nephropathy compared to other diseases that can cause renal failure in the same patient population. Number 1 is the onset of proteinuria. Less than 5 years from the onset of diabetic type 1, it will make it less likely to be related to diabetes, and you have to look for another cause. If the acute renal failure happened, if it happened acutely, this is most likely you need to look for other cause other than diabetes. Number 3, the presence of an active urine sediment, particularly if you see an athenocytes or a cellular cast. And this is why it's very, very important to send your patient urine for urine analysis and to look for cellular cast. This will make it unlikely that it's related to diabetes, and you have to find another cause that you can treat to prevent further progression. In type 1 diabetics, the absence of diabetic retinopathy or neuropathy, and there is nephropathy, usually this doesn't fit. Usually nephropathy will be preceded by retinopathy and neuropathy, which will occur much earlier than nephropathy. Therefore, if you have a patient diabetic type 1 who have nephropathy, then that he have nephropathy without retinopathy or neuropathy, then please look for another cause other than diabetes. Maybe you can treat. Number 5, if there is any signs of symptoms for another systemic disease. And number 6, if there is significant reduction of glomerular filtration rate, more than 30% within 2 to 3 months, this is usually not related to diabetes. If it happens so acutely and so fast, usually you have to send your patient for a kidney biopsy to check for other causes other than diabetes. Maybe you can treat and prevent further progression. Risk factor for diabetic nephropathy, as we just said, family history of diabetes and diabetic nephropathy will make it most likely that it will happen to all the other siblings. Black race, certain ethnicities like Mexican and American and Indians, higher systemic blood pressure. So if there is diabetes and uncontrolled blood pressure, this will make it higher chance for the patient to develop diabetic nephropathy. If there is an evidence of hyperfiltration, or if there is a poor glycemic control, smoking, and obesity. Treatment and prevention of diabetic nephropathy. Again, good diabetic control. Good blood pressure control now is also, as we said, is a very important factor for prevention of progression of diabetic nephropathy. So controlling the blood pressure with less than 130/80 is your target, and ACE and ARB is your preferred agent. And ACE and ARB is your preferred agent, especially if you have macroalbuminuria, that it will prevent this kind of complication. You also have to treat hyperlipidemia, and if progressed, renal replacement therapy and renal transplantation is the end treatment for diabetic nephropathy that can be leading to end-stage renal disease. Screening for diabetic nephropathy, usually the blood pressure, you check it every visit and make sure that the blood pressure is well controlled at home, not only in your clinic. So you let the patient really record in a weekly basis or in a daily basis his blood pressure recording and measurement. For urine albumin ratio, for urine albumin to creatinine ratio, you do it in a yearly basis. You begin with 3 to 5 years after the onset of diabetes type 1, and the serum creatinine, you do it annually, not every 3 months. Except if you find there is a progression or a renal disease, then you have to do it in a much shorter duration. Causes of transient proteinuria. So you might see a proteinuria in your patient that it is unusual, that you never saw in his previous visit in 3 months ago. Then you have to think about other causes for a transient proteinuria. Number one is febrile illness. It is very common that the patient will get a febrile illness that will lead to proteinuria. Urinary tract infection is the other cause. Recent major exercise, decompensated heart failure, menstruation, acute severe elevation of blood sugar, and acute severe elevation of blood pressure. I hope you are not tired yet of diabetic complication. We will move to a new category. We'll speak about the nervous system complication of diabetes. First, you have to remember that diabetic neuropathy is usually the first chronic complication to occur, especially if the patient is not controlling his blood sugar very well. This is usually a very common presentation that the patients will complain of, and it gives you a hint of their poor compliance for their medication. And therefore, if you always remember that this diabetic neuropathy is the earliest one to occur, then it will give you hints to give more time to advise your patient. Especially that this neuropathy will lead to a lot of other complications, most commonly diabetic foot. And this will usually lead to immobilization, and therefore it will lead to worsening complication of this diabetic patient. So let's move on. The first and the most common one is peripheral sensory neuropathy, which is distal symmetric sensory loss. The second type is the motor neuropathy, which is foot drop, wrist drop, mononeuropathy, and cranial neuropathy. It can occur as neuropathy in cranial nerve 3, 5, 7, which is most commonly seen. Autonomic neuropathy, which can lead to postural hypotension, resting tachycardia, loss of sweating, gastrointestinal neuropathy, gastroparesis, diabetic diarrhea, urinary bladder autonomy, and impotence. So diabetic neuropathy. It's the involvement of the peripheral autonomic nervous system, most common complication in diabetes. The clinical diabetic neuropathy is categorized by distant syndrome according to the neurological distribution, although it might overlap the syndrome that can occur. The prevalence is function of the disease, the duration, and based upon several large studies, there is approximately 50% of the patients with diabetes will eventually develop neuropathy. In our study, as we said, peripheral neuropathy will occur in Saudi patients around 13.2%, which is less than what we just said, about 50%. But remember, it is a very common complication. And it's usually the first to occur. You can see the median is around 10 years, plus minus 2, compared to the others which were around 12 and 13 years. It has been confirmed in many other studies, and the best part that will lead to and the risk factors of diabetic nephropathy and the risk factors of diabetic neuropathy is, as we just always said, glycemic control, duration of diabetes, damage of the blood vessel, mechanical injury to the nerves, autoimmune factor, genetic susceptibility, and lifestyle. So smoking and diet will be a higher risk factor of this complication. Systemic sensory polyneuropathy. It's the most common diabetic neuropathy. Sensory involvement usually occur in the first, generally bilateral, symmetrical, associated with decreased perception, vibration, and temperature. Paresthesia and dysesthesia may occur usually after a distal lower extremity, like what we always abbreviate stocking glove sensory loss. Pain, when present, it can range from mild discomfort to a severe pain. Complication of this severe polyneuropathy is usually, as we see a lot in our patient, recurrent ulcers, Charcot arthropathy, discoloration and stress fracture, and unfortunately, the end result, it will lead to amputation. The treatment of systemic polyneuropathy is usually, as every other complication, is very good glycemic control. But don't let your patient suffer. Remember that you need to treat this painful complication by tricyclic antidepressant, amitriptyline, or typical creams. Also, anticonvulsants like gabapentin can be used, and always emphasize in the very good foot care to prevent ulcers and further injuries to the foot. The second type of diabetic neuropathy is polyradiculopathy, which can be one of few types. It can be lumbar, which will cause thigh pain. Your patients will complain of bilateral pains in the thighs and can accompanied by weakness, and especially if he is climbing the stairs. Thoracic type is he will complain like a band around his abdomen. And this band will always have pain and will always have numbness in it. Diabetic neuropathic cachexia, which is systematic peripheral neuropathy with affecting both proximal lower limbs and hands and lower trunk. It's associated with profound weakness and weight loss and painful dyskinesia, which will be associated mainly with depression. The treatment is usually foot care, glycemic control, and pain control. Don't let your patient suffer. Please control his pain very well. Mononeuropathy, it can be a single nerve that is damaged due to compression or ischemia. It can occur in the wrist, and usually the symptoms will be numbness, edema, pain, pricking, or it can be the cranial mononeuropathy, as we said. It can be one of the mononeuropathy of the cranial nerves. The treatment is glycemic control and pain control. Autonomic neuropathy, on the other hand, it can affect the autonomic nervous system, which can affect the genitourinary, cardiovascular, and it can be classified as clinical or subclinical based on the presence of symptoms. It can contribute to the following signs. It can lead to Charcot joint or Charcot foot, aching, pulsating, tightness, cramping of the dry skin. It can lead to sweating abnormalities and weakening of the bone of the foot that can lead to further fractures. The most important part is testing. Direct recording of postprandial filament fibers, and then you will check his nervous sensation in every visit and measurement of his vascular response. The treatment, as most of the neuropathies, is to watch for diabetic care, diabetic care, diabetic foot care, diabetic foot care. Elevate the feet when he is sitting, eliminate the aggressive drugs, reduce edema. You might use some diuretics to decrease the edema, and to screen for peripheral vascular disease and coronary vascular disease, and you might support it with stockings. Genitourinary autonomic neuropathy. We will speak about certain types and the treatment. Number one is bladder dysfunction, and the treatment usually is voluntary urination. Sometimes it might need voluntary catheterization. Retrograde ejaculation is usually treated by antihistamine. Erectile dysfunction, and this is a very important complication. It causes your diabetic patients to go into depression. So please ask about this complication. Ask your patient if he's having erectile dysfunction. Don't let it move on into becoming a very significant complication. Make it a regular checkup in your questionnaire for your patient. If he's having mild erectile dysfunction, then you can help him in prescribing like sildenafil or any of the agents that will help this erectile dysfunction, or refer him to a urologist, because sexual life is a very important issue in any patient, but also in diabetic patient, it's a very life-changing for them. Dyspareunia, and your female patients will complain of that, and you can treat it by lubricant and estrogen creams. Gastrointestinal autonomic neuropathy. If you look at your patients closely, you will find this is a very common complaint. They will complain of the food is not moving on, there is bloating, there is decrease of gastric emptying, and usually if you look at those patients, you will find they have a very poor diabetic control. The signs and symptoms will be gastroparesis resulting in anorexia, nausea, and vomiting, diabetic enteropathy resulting in diarrhea and constipation, and the treatment of this is a very important issue for a lot of our patients. The usual treatment is to prescribe small, frequent meals. You can use metoclopramide, erythromycin, or domperidone. In some selected patients, you can have a botulism toxin that is injected into the pylorus that can reduce the sphincter resistance, which will make the gastric emptying much easier. The gastric electrical stimulation have been reported to improve symptoms and quality in life of diabetic patient with gastroparesis and refractory for pharmacological therapy. Enteropathy is also another modality of treatment of gastrointestinal autonomic neuropathy. The cardiovascular autonomic neuropathy, it's usually the symptoms will be exercise intolerance or postural hypotension. And the treatment is usually to discontinue the contributing factor, mainly it's medication, and also to ask your patient that when he never change his posture, that he have to do it slowly rather than fast, rapid change in his posture. Because we were speaking about the cardiovascular autonomic complication, now we have to move to the chronic complication of diabetes related to the cardiovascular system. And mainly it is heart disease, ischemic heart disease, cardiomyopathy, peripheral vascular disease, and cerebrovascular disease. As you all know, the absolute risk factor of myocardial infarction is much, much higher in diabetics compared to non-diabetic patients, and usually it can occur also as a silent MI rather than your normal patients. And it has been shown in many, many slides. One of them is shown in this slide that was published in Diabetic Care in 1993 that shows that people with diabetes have a higher impact. And it's not only the occurrence of myocardial infarction in diabetics is more prevalent than non-diabetic. Also, it has been shown in many studies, like the one we can see in the slide, the MERFT study that was published in Diabetic Care in 1993 that showed if you compare the mortality from a cardiovascular attack or an MI, if you compare diabetic with other risk factors like hyperlipidemia or smoking or hypertension, the diabetic patients will have a higher mortality from myocardial infarction compared to other patients. This wasn't the only study that confirmed that diabetic patients can have higher mortality rate compared to non-diabetic patient. Also, if the patient have prior MI or non-prior MI, the factor of being diabetic will increase the chance of mortality. This is also confirmed by a New England Journal of Medicine publication in 1998, which shows that you have a higher tendency, as you can see in the slide, to have a higher mortality if you are diabetic with a prior MI compared to non-diabetic patients. In the other study that is published in the Archive of Internal Medicine in 2001, the T2DM, for more than 15 years, they were following more than 121,000 patients, women mainly of age 30 to 55, they had a higher chance of coronary heart disease with diabetic compared to non-diabetic patients. And if we compare individual with diabetes or without diabetes, if they have MI or non-MI, the study that is published in Circulation in 2004 that you can see in the graph, if the patient does not have diabetes or prior MI, the calculated death from non-fatal MI is around 3.9% compared to 32.2% if he had diabetes with MI. If he had diabetes only without prior MI, the chance is also around 10.8. So you can see the much higher chance of mortality if they are diabetic with an MI compared to non-diabetic patients. They estimate that the risk of ischemic stroke, if we go to the other part of the body, which is the brain, they estimate that the risk of ischemic stroke in diabetic patients will be 2 to 3 folds increased in men and 2 to 5 folds increased in women who are diabetic compared to non-diabetic patients. And also the recurrence of stroke will double if the patient is diabetic compared to non-diabetic patient. Stroke outcome will significantly be worse if the patient is diabetic compared to non-diabetic patients. Diabetes and peripheral vascular disease, it's usually a clinical manifestation that will include ischemia of the lower extremity, impotence, and intestinal angina. The true prevalence of peripheral vascular disease is usually difficult in patients with diabetes to determine because most of the patients are asymptomatic until they develop complication. If you age adjust, amputation rate in diabetics is around 8 in 1,000 patient years with a prevalence of around 3%. The incidence of gangrene foot in people with diabetics is 30 times higher in diabetics compared to non-diabetic patients in an age-matched control. And therefore, assessing your patient peripheral circulation is very important in the patient visit. You can do that by the capillary refill. You make sure by his temperature, arthropathy, and arteriobrachial index. And arteriobrachial index, the ABI indicate. If it's normal, it will be more than 0.9 to 1.2. If it's claudication, it will be between 0.5 to 0.9. Critical ischemia is usually less than 0.5. And if we look into the study that we have been talking about since the beginning of the lecture, ischemic heart disease and coronary artery disease is the third most common complication that occur in diabetic patients in Saudi Arabia of around 23%. And usually it will occur between 12 to 15 years from the time of diagnosis of diabetes. And therefore, the ADA recommendation for statins, which is the mainstay for prevention of coronary artery disease or peripheral vascular disease, is to control diabetes, hypertension, and hyperlipidemia. And therefore, the use of statins and in the treatment of diabetes, if it's less than 40 with no risk factor for coronary artery disease, you evaluate annually by a lipid profile. If he's in the age of 40 to 75 with no cardiac vascular disease risk factor, he is in a moderate to high recommendation for statin, and you need to monitor his adherence. If he is more than 75 years, if he is with no risk factors for coronary artery disease, then it's moderate. If he have risk factors, then it's moderate to high. And if he have a coronary artery disease, then it's high recommendation that you start your patient on statins. Statins therapy should be used to reduce cardiovascular risk in adults in type 1 and type 2 diabetics following the following features. If he is more than age of 40 or less than the age of 40. If he's more than age of 40, then start the patient statins. If he's less than age of 40 with diabetes for more than 15 years or age more than 30 in diabetic type 1, microvascular complication, then they are warranty a treatment with statins. The target for dyslipidemia treatment on those patients is, as you can see, according to the American Diabetes Association, the primary target is to decrease the LDL below 2.5 millimole, which is around 100 milligram per deciliter in patients with known coronary artery disease. Secondary prevention, then you push it furthermore to decrease the cholesterol below 1, an LDL between 2.5 to 3.35, which is around 100 to 129 milligram per deciliter. If you can't reach that, so you might use fibrate or niacin, especially in patients who are intolerant to statin. The Canadian guidelines say that the LDL should be lower than 2, which is 77 milligram per deciliter, and secondary target non-HDL will be less than 2.6, which is less than 100. Or an apolipoprotein B level of less than 0.8. And you can see this is a very busy slide, but you can see very clearly the table which will describe the target of dyslipidemia treatment with diabetes in an adult treatment panel. Now we will move on to the aspirin treatment for the recommendation in diabetic patients. Aspirin of 75 or 162 milligram per day is recommended for secondary prevention in diabetic patients with history of MI, vascular bypass, stroke or transient ischemic attack or peripheral vascular disease. Aspirin 75 milligram is recommended as primary prevention in any patient with diabetes with an increased cardiovascular risk, 10 years risk of more than 10%, which would include most men aged more than 50 or women aged more than 60. If you have a patient diabetic age more than 50 or a woman age more than 60 with an additional cardiovascular risk factor like smoking, like hypertension, obesity, or albuminuria, or a family history of coronary artery disease, then it is recommended to use aspirin in those patients as primary prevention. So let's repeat this again. If you have a patient, when can you use it as primary prevention? If you have a patient who is male more than 50, female more than 60, with another risk factor that is like smoking, family history, hyperlipidemia, then use aspirin, please, as primary prevention. Aspirin is not recommended for diabetic patients under the age of 30 due to the lack of evidence of benefit. Aspirin is contraindicated to age 21 years old or below due to the increased risk of Ray's syndrome. Plavix, or 25 milligram per day, is recommended in patients with coronary vascular disease and documented aspirin allergy. So what are the vascular protection checklist? First, check your hemoglobin A1C. You need to keep it around 7 or less. Blood pressure control. You need to keep the blood pressure below 130/80. Number 3, cholesterol. You keep LDL below 2. If indicated, then you move on the target furthermore. Drugs protection. You have to always think, does your patient need statin? Does he need ARB or ACE if he have macroalbuminuria? Is aspirin indicated? This is like your checklist in every visit. Exercise, eating healthy. You make sure that your patient exercise in a regular basis. And don't forget that to try to help your patient by emphasizing that he needs to do smoking cessation, which can be helped by medication those days, and you need to convince your patient that this is one of the most important factors to prevent complication that he can have from diabetes. Just to consolidate everything we have said and to recap all the importance factors of decreasing the complication of diabetes, remember that your diabetic control is the main target. It has been seen in this slide with an elegant study that was published in New England Journal of Medicine in 1993. Since that time, it has been shown that all the microvascular complication can be decreased by diabetic glycemic control. So you can see the hemoglobin A1C, the worse it is, the higher chance of relative risk of developing microcomplication. This is also have been proven in UKPDS that every 1% drop in hemoglobin A1C, it can reduce diabetic complications significantly. Like lower limb complication, it can be decreased by 43%. Microvascular disease by 37%. Cataract complication by 19%. Heart disease, myocardial infarction, and stroke can be decreased by 16 to 12%. This is what you should advise your patient. Your patient should understand very well that every time he comes to the clinic with a drop in his hemoglobin A1C by even 1%, he will decrease significantly the chance of complication. You need to have this graph with you in the clinic. You need to show the patient that every 1% have a very significant meaning in his life. We will go back to the diabetic foot as our last chronic complication that we see a lot in Saudi Arabia. The foot of a diabetic patient that has a potential risk for pathological consequence, including infection, ulceration, destruction of deep tissue. It is associated with neurologic abnormalities with various degrees of peripheral vascular disease. Metabolic complication of diabetes of the lower limb is significant. Diabetic foot, it is estimated that 15% of patients with diabetes will suffer from a diabetic foot during their lifetime. Although the accurate figure is difficult to obtain, but the peripheral of diabetic foot ulcers is around 4 to 27% in different studies that you look at. Approximately 20% of the hospital admission among patients with diabetic are related to diabetic foots. Overall, the rate of lower limb amputation, which lead to this mobility and sedentary lifestyle, and the patient lose most of his activity. Unfortunately, the overall rate in diabetics is 15 times higher than non-diabetic patients. It is estimated that approximately 50 to 70% of the lower limb amputations is related to diabetes. In Saudi Arabia, 13.5% of diabetic patients refer to neuropathy clinics, and 7.7% undergo chronic hemodialysis. Amputation is required between 12 to 62. Around 19% of diabetic patients will have ulcers and can lead to amputation in Saudi Arabia. It is a pretty prevalent disease, as you can see in the graph in our study. Also, it has been confirmed in the second study that was published in Al-Hasa. Remember that the pathophysiology and the risk factor for diabetic foot, it is divided into between neuropathy, losing sensation, and angiopathy, which is related to vasculature. And this is what you have to always remember. Checking your patient vascularity and checking his sensation is critical in preventing complication of his diabetic foot that will lead to amputation, unfortunately, and will lead to further complication of the patient. So the diabetic foot assessment is you have to ask for prior history of foot ulcer, and you have to look for the appearance of the foot, the color, the nails, symmetry, swallowing, deformity, and you have to assess the skin. If there is hair, the color, the thickness of the skin, if there is any cracking, and then you can advise the patient to take care of that rather than getting more cracking into the skin that will lead to further infection, will lead to further complication of the diabetic foot. You have to assess his circulation, and you assess his sensation by a 10-gram microfilament test once every time that he visits. It's important to check that before your patient will lead and go into the full diabetic neuropathy and he lose total sensation. You have to investigate and discover it much earlier before he goes into this complication. And you have to inspect the patient footwear. Unfortunately, in Saudi, there is a lot of footwear that are unsuitable for diabetic patients. It will lead to further ulceration and friction, which will cause further infection and further complication. Diabetic foot risk categories is very obvious, seen in this table, and you can go through it or keep it in your clinic. Foot care, you always advise your doctor. If you have a neuropathy, you always ask the patient to tell his physician if he have neuropathy. You ask your patient to check his feet daily for any cuts, blister, redness. You ask him to wash his feet daily and dry it carefully, especially after wudu. He have to dry it rather than to leave it wet. Use lotions to prevent dryness. Do a regular nail cuts. Wear stocks and well-fitting shoes. Never walk barefoot, even indoors, which is unfortunately a common misbehavior that diabetics do. Do ask him to quit smoking and controlling his diabetes. The last slide will speak about some of the other diabetic complications. Some of them are related to the skin, like the diabetic dermatopathy, which is very common and you see it in a lot of patients. Candidiasis and foot and leg ulceration. Some of the bone deformities like diabetic Charcot joint and unusual infections like necrotizing fasciitis, necrotizing myositis, and a malignant otitis externa, which is something that you have to watch for because it can lead to further complication from fungal infection in diabetic patients. Remember that a lot of complications have significantly, as you can see in this graph, in a in a study published in New England Journal of Medicine 2004 that shows significant reduction of the diabetic complication in the past 2 decades, secondary to wonderful control of diabetes in other countries. So our main target is to work hardly in controlling diabetes in our population so we can reach this kind of drop in the chronic diabetic complication. This is your master slide and master table. You can print it and keep it in your office. This is monitoring your patient with diabetes mellitus. I wish and I hope that we made diabetic complications so clear. Now you have enough knowledge to take well care of your patient. I wish you all the best, and assalamu alaikum.